30-day mortality, 30-day mortality and hospice. And we included English language published and unpublished data, analytical epidemiological studies, including retrospective or prospective cohort, case-controlled studies, meta-analysis, randomized controlled trials, and systematic reviews that reported the 30-day mortality for patients that had advanced cancer who had received palliative radiotherapy. So this is a Prisma diagram showing our screening process. And at the top, you can see the databases we searched. We found a total of, with our initial search, we found a total of 1,259 records, and also an additional 13 records through other sources like the reference mining and related search function from PubMed. And duplicates were removed, and we were left with 946 records at that stage. And we, two independent reviewers went through an initial screening process looking at the abstracts only of those records. And 857 of those records were excluded based on abstract screening looking for 30-day mortality, palliative radiotherapy. And we were left with 89 studies at that stage. And those 89 went through a full text screening by two independent reviewers. And at that stage, 29 of those studies were excluded for the reasons you can see on the right. And that left us with 60 studies. And those were then merged into 43 studies based on some studies reporting on the same population of patients. And 15 of those 43 were abstract-only studies or publications, and 28 were full-text studies that were published. One of those 43 was a systematic review, which I'll talk about later. We did not extract directly from that systematic review to avoid duplication of our data. So the overall results of the 42 studies that we extracted data from, those studies totaled 88,516 patients that had advanced or metastatic cancer that had palliative radiotherapy. We found that there was a high heterogeneity in the population, so the I-squared value was 99%, and that was significantly high. And of the total number of patients of all the studies, 18,958 of them had died within 30 days of their palliative radiotherapy. So that was a raw proportion of 21.4%. But there was a high range of the proportion of the 30-day mortality from as low as 5% in one study to as high as 45%. So overall, we found the summary effect for 30-day mortality rate after palliative radiotherapy was 16%, with 95% confidence intervals between 14 and 18%. So looking a bit at the demographics of the patients, so of the 42 studies, they originated from 14 different countries around the world. There was one pediatric only study, which included patients with a median age of 10 years of age. Median age range of all the other 41 studies was between 61 years of age and 80 years of age. 16 of the 42 studies reported gender, and of those, 41% of the patients were female gender. That was 16,575 of the 40,742 that reported that. Most of the study, 76%, included patients being treated for multiple primary sites of cancer. Lung cancer was the most common primary that was focused on. 8 of the 42 studies looked at lung cancer alone, and patients with lung cancer getting palliative radiotherapy. And 6 of the 42 studies we extracted from focused on palliative radiotherapy for bone metastases as an indication. So this is a forest plot giving you all 42 studies that we extracted data from that were included. And you can see the wide-ranging 30-day mortality rates from that forest plot. At the bottom, the black diamond indicates the summary effect, and the width is the confidence intervals for that summary effect. So you can see a lot of those studies that we included their confidence intervals fell outside of that summary effect, 16%, and its confidence intervals. And so that's an indication there was high heterogeneity as well. The two biggest studies that we included, one was from the state of Queensland in Australia, and this is in the process of being published, but it's already been published online. Queensland's unique because in Australia they have private and public private and public centers that provide radiotherapy to patients, and so it was a mix of those, and it had a significantly higher 30-day mortality rate than our summary effect. The total number of patients that were looked at over several years was 22,501 that underwent palliative radiotherapy for their advanced or metastatic cancer. And there was the other biggest study was Murphy 2013, which is an American study that was done using the SEER database. The SEER database is interesting because they collect data on patients in several states in the US that had Medicare coverage, which you would only qualify for if you were above 65 years of age or you had qualifying disability, such as chronic renal failure or something like that. So it may be excluding a certain subset of patients getting palliative radiotherapy. But both of those studies had a higher 30-day mortality rate after their PR. And based on the high heterogeneity, we looked at secondary outcomes and subgroups. So we did some subgroup analysis. The secondary outcomes of interest were number of fractions of palliative radiotherapy planned, and we broke that up into different groupings of fractionations. Number of patients not completing treatment, the use of advanced radiation technology, including SBRT versus VMAT versus single field beam palliative radiotherapy. And the subgroups we were interested in, some of them were indications for palliative radiotherapy, for example, palliative radiotherapy for bone metastases, painful bone metastases, primary cancers, inpatient status, ECOG score groupings, and other subgroups we looked at were patient age, study date, so whether it was prior to 2016 or after, US studies versus others, so the rest of the world versus the US, patients with liver metastases, those getting synchronous chemotherapy, those known to hospice, and the timing of 30-day mortality, whether some studies started that 30 days at the end of patient's treatment, and some started that count at the beginning of their PR treatment. So just looking at that as a subgroup. We did some small study, we looked at whether there was small study effect or publication bias. Because this meta-analysis was just a single arm meta-analysis, that publication bias is less of a factor. But you can see in the funnel plot on the left that there was quite a variation of scatter in the scatter plot, in the funnel plot, indicating that there was, that's displaying that there's definitely a high heterogeneity of the population of studies reporting the 30-day mortality after PR. We went a bit further and looked at a scatter plot on the right-hand side displaying study sample size as a measure of precision. And again, it wasn't clear whether there was small study effect or publication bias. And then we did some statistical analysis and we found there was non-significant publication or small study effect. So just looking at the subgroups now, I'm not going to go through all the subgroups because there's so many. Just looking at the ones that were statistically significantly either higher in terms of 30-day mortality after PR or lower. And so the ones that were significant, not the ones that were not significantly different from our summary effect of 16% mortality after PR. So the first groups are the ones that are higher 30-day mortality rate after PR. So the first one was patients getting treatment at multiple treatment sites for palliative radiotherapy. So patients that were treated in different parts of their body at the same time. And they had a significantly higher 30-day mortality rate after PR. It was about 31%. There was only one study, though, that was included. It was a small study. And the next one is patients with hepatobiliary primary. They had a slightly higher 30-day mortality rate, but it was significant, and that was 27%. Melanoma, patients with melanoma also had just barely a statistically significantly higher 30-day mortality rate. And patients with mesothelioma also had a higher 30-day mortality rate compared to our summary effect, 16%. In patients as well as a group, had a significantly higher 30-day mortality rate. They actually had the highest 30-day mortality rate as a subgroup, and it was 40%. And also, not surprisingly, patients with ECOG score 3 to 4 as a subgroup had a higher 30-day mortality rate after their PR treatment. Patients with liver metastases that were getting palliative radiotherapy also had a higher 30-day mortality rate after their PR. And also patients not completing their treatment of PR had a higher 30-day mortality rate after their treatment. Interestingly, US studies versus studies from the rest of the world had a higher 30-day mortality rate after their PR. Looking at the subgroups that had a lower 30-day mortality rate after PR now. So patients with ECOG score 0 to 1 had a lower 30-day mortality rate. It was only 4% there after their PR. Those getting synchronous chemo also had a significantly lower 30-day mortality rate after PR. And we were able to get some data from a study on SBRT, stereotactic radiotherapy, for brain metastases specifically, and they also had a lower 30-day mortality rate after their PR. So a worldwide benchmark 30-day mortality rate for those getting PR may be 16%, but individual treatment centers must recognize the high degree of heterogeneity in the studies included, as well as some of them being of high risk of bias. So 22 out of the 42 studies that we looked at, that we extracted from, had at least one domain that was assessed as high risk of bias. US centers may have a higher 30-day mortality rate after PR based on subgroup analysis compared to the rest of the world. So more study is needed to determine why this may be. Secondary outcomes and subgroups that were associated with a higher 30-day mortality rate after their PR included patients getting PR at multiple treatment sites, those not completing their treatment, inpatients at the time of referral that had the highest 30-day mortality, certain histological diagnoses, including hepatobiliary, melanoma, and mesothelioma, patients with ECOG scores 3 to 4, and those with liver metastases as well. The ones that had lower 30-day mortality rates after PR was those with ECOG score 0 to 1, those getting synchronous chemo, and those getting stereotactic radiation for brain metastases. So looking at the limitations of our review at the study level, so there were numerous ways different studies identified patients getting PR, which was an issue. Some studies didn't report how they collected their data at all. Some studies looked at retrospectively at mortality, deaths that were reported, and of those who had cancer and of those who had underwent palliative radiotherapy. So they went backwards. I guess the problem with that is if you have a short study period, then at the end of the period, there will still be patients alive after that time that had palliative radiotherapy, but that weren't counted in the study because they were still alive after the study period ended. So that may introduce some bias, especially for studies that were shorter in duration. There was also inconsistently reported outcomes for patients getting PR in the studies. Unfortunately, we also wanted to look at a lot of other subgroups, and those included different indications, such as patients getting PR for bleeding, threatened airway, dyspnea, spinal cord compression as well. It would have been interesting to see some data on those, but unfortunately we didn't get enough data from the studies and so they weren't reporting the numbers that had palliative radiotherapy in total and the ones that died that had palliative radiotherapy for those indications. Also, gamma knife wasn't reported at all in the studies we extracted data from, and it would have been interesting to see those getting steroid treatment while they were getting PR as well. Whether that was a subgroup that would have been significantly different, who knows? And also I talked a little bit about the inconsistently reported or used technique for measuring the 30-day mortality after PR. So some studies looked at that 30 days starting from the beginning of the patient's treatment and some from the end. It was a bit of a mix, but that wasn't a subgroup that was statistically significantly different when we analyzed it as a subgroup. At the review level, there was a high risk of bias for studies from a missing data domain that existed due to many studies, 16 out of the 42 that we extracted from, not reporting numbers of patients lost to follow-up or the ones that were excluded from the study. And we also excluded non-English language studies as well. So our meta-analysis of published and unpublished data of 42 studies is the largest to date and represents the best estimate and a starting point for a quality metric. This was also the only meta-analysis that's been published to date on this topic for palliative radiotherapy. There was a prior systematic review in 2017 by Park et al. That included 20 studies that showed a range of between 9 and 15% as the overall 30-day mortality after PR, which matches close to our 16% number. There is a current UK guideline that suggests a benchmark of no more than 20% of centers offering palliative radiotherapy. So no more, they shouldn't have a 30-day mortality rate of more than 20%. But that's limited. That's not underpinned by any evidence really. And so we suggest using a 30-day mortality rate of 16% as our quality metric and define sites that fall outside of this metric. Subgroups found in our meta-analysis to be associated with the higher 30-day mortality rate after PR can be used to audit local radiotherapy data to guide for future changes to provision of appropriate PR treatment as well. And that's it. I'm happy to answer any questions or any comments or facilitate some discussion as well amongst you guys. It'd be interesting to hear from the radiation oncologists about what you think in terms of the Sunnybrook as a center giving palliative radiotherapy. One thing I've noticed working here, I'm new here, but being here for a couple months, is I'm anecdotally noticing more patients getting stereotactic radiation for palliative radiotherapy purposes, and just wondering what sort of indications or what patient populations you guys are using that for, and whether that's based on some new evidence coming out about stereotactic radiation for patients with advanced cancer as well. If anybody wants to answer that or comment on that, that would be interesting to know from a palliative care point of view.
Hi, I have a question. Thank you for that very interesting presentation. In your data, did you have data for the trajectory of when they actually were diagnosed with their cancer versus the time of their palliative radiation? And in terms of a longer disease-free survival would indicate a better outcome than a shorter disease-free survival. And nowadays, there's a lot of molecular analysis going on, and that has big implications. So did your data? It's probably too recent, but was there any molecular profiling data available?
Yeah, that's a really good question. So generally, we didn't have any data on that. We couldn't, that wasn't really reported. I guess because our primary outcome was looking at 30-day mortality after the palliative radiotherapy, we didn't look at a subgroup analysis of how long those patients would have been diagnosed, like when they would have been diagnosed compared to when they had their palliative radiotherapy. A lot of those patients that are included in the studies we extracted from would have had multiple courses of palliative radiotherapy. And it gets really complicated if you want to sort of parse that apart. I mean, you could look at number of treatments, I guess, would be interesting to know of palliative radiotherapy or courses of radiation in general that patients would have undergone prior to the last course of their last course of PR. But nobody really reported the data in that way to make it, usable for our study based on our primary outcome. And it also would have been it would be really interesting in general to look at the subgroup of patients getting targeted treatment or immunotherapy. But again, I think it's just too new, and the studies that were reporting the 30-day mortality rate weren't really reporting that as a group either. So it wasn't really the focus of those studies. I don't know if that's because it's too new or whether it just wasn't looked at as part of their audits they did or studies that they did. But yeah, that's a really good question. Any other questions? It's a palliative treatment is becoming a blurred area, isn't it? I mean, or a gray area really, because we're seeing patients that are being treated for longer, like an immunotherapy or targeted treatment as an example. We're going to see patients getting treated in a more advanced stage of their disease in the future, and so they will be living longer and probably getting more palliative radiotherapy as well. And we're seeing patients with this oligometastatic disease of cancer that is being treated with probably being treated more with stereotactic radiotherapy, which is my understanding is a more ablative treatment. And so they obviously would have a much better prognosis as well. An example is the stereotactic brain radiation for brain mets, which our study found had a lower 30-day mortality rate. But it'd be interesting to hear from you guys if you what your practice is like there, and any comments on that as well.
Actually, if there isn't another question, I'd like to ask another question.
Sure.
Looking at your data, you looked at 30-day mortality. Is that the right endpoint? And because when you're looking at palliative radiation, it's not just the mortality, but it's also symptom control. And it may be reasonable to offer palliative radiation purely for symptom control rather than for mortality.
Yeah, that's right. Exactly. It's a bit of a blunt benchmark, isn't it? And the high heterogeneity also it makes it important to look at the subgroups when you're looking at your own data. I think that's exactly right. So it's not so much not giving the treatment, it's more sort of looking at trying to get an idea of the patients that maybe have a poor prognosis and offering them more of a hypofractionated treatment. If they do have symptoms that you think would be amenable to the treatment. I'm not a radiation oncologist, of course, and you guys can speak to that better. But yeah, it's more about choosing more wisely, giving more hypofractionated treatments for patients with poor prognosis or that might have a higher 30-day mortality rate. I guess just taking that into consideration as one of the things that you would consider when treating patients that have advanced cancer, to make sure that, especially patients that have bone metastases that are not complex, that are not complicated by neuropathic pain or nerve involvement, treating those patients with hypofractionated courses of radiotherapy. We know that one fraction, there's a lot of evidence to show that one fraction is as good as more than one fraction for simple pain from simple bone metastases. So just I guess keeping that in mind when treating patients with advanced cancer is important. Any other questions? Let's see, there's a couple chat things. Finished pizza, lunch, and beverages in front of Jenkin Auditorium. And somebody said, thanks for the talk, Justin. Any other questions at all?